Hello, and welcome to another episode of the Availity On Air podcast. I'm your host, Matt Schlossberg, Director of PR and Communications at Availity. Here on Availity On Air, we dive into the most pressing topics in healthcare technology and business, exploring the innovative solutions that are shaping our industry. Today, I'm joined by Ashley Basile, Chief Product Officer of Clinical Solutions at Availity, to discuss payer-to-payer data exchange, a crucial topic driving interoperability and transforming the way health plans share member data. Together, we'll explore the CMS final rule on interoperability, the challenges and opportunities for health plans, and how Availity is paving the way with its P2P connectivity hub. Whether you're a health plan executive, a provider, or just passionate about healthcare technology, this episode is packed with insights you won't want to miss. Let's dive in. Ashley, welcome to the podcast.
Thank you so much, Matt. I'm delighted to be here today.
So I wanted to really kind of start off with our discussion on payer-to-payer data exchange by asking you to kind of briefly introduce the concept of P2P and explain why it's become such a crucial capability in the industry.
Absolutely. And I always think, before diving specifically into payer-to-payer data exchange, it's helpful to take a quick step back and discuss the CMS interoperability and prior authorization final rule, which payer-to-payer sits under. So this final rule, it's known as CMS 0057, or more commonly as the, quote unquote interop rule. But it's a government regulation which was finalized just about this time last year, actually, and it builds on the foundation set forth in the patient access rule. That really was the first rule to establish under the 20th Century Cures Act, FHIR as a data standard of adoption to really improve and drive data interoperability between providers and health plans, with the ultimate goal to improve patient care. And this interop rule states that by January 1st, 2027, which is going to come much faster than we all think, it will be mandatory for all affected payers, and that includes Medicare, Medicaid, and exchange plans, to implement FHIR application programming interfaces, or APIs. And there's specifically 4 APIs included in this rule. The first one, payer-to-payer API, and that's for member data sharing between health plans. Second is a prior authorization API to really drive transparency and efficiency. Third is a provider access API for care coordination. And lastly, the patient access API for data accessibility. So that's kind of at a high level, a little bit of an overview around the prior authorization final rule, the interop final rule. But to specifically dig into payer-to-payer, with the final ruling, impacted payers are required by January 1st, 2027 to implement and maintain payer-to-payer APIs to exchange clinical, claims, and authorization data when a member moves between health plans. And so, I just gave you a lot of details, but what does that exactly mean? Why whoever is listening to us today should they care? And I always think it's helpful to talk through an example and make it a little more real. So let me ask you, Matt, on average, how many times have you changed health plans over the course of your career?
I would say every time I've changed a job, but I do get offered
Mhm.
that, within jobs, as the employer changes health plans. But I would say every time I've moved on from a job.
And would you value, as you change jobs, having your new health plan know all of your medical history, all of your healthcare information that kind of has preceded you and been collected by your prior health plan?
Yeah, for multiple reasons, I think I would like to have that. Not just
Yeah.
administrator, but the fact that, of being able to my data to move along with me, would be, kind of comforting, rather than it lingering out in an organization I don't interact with anymore.
Absolutely. And that is really the intent around the payer-to-payer mandate, is as a member moves from an old health plan to a new health plan, should they give approval for their new health plan to reach back out to their old health plan and gather all of that information. And I can give you a really quick example too. It was incredibly frustrating for me. About 5 years ago, I had just changed jobs and recently had also just delivered my first child, and I had to have some post follow-up care. And I went to the new doctor, and they were asking for all of my historical information. I was in the middle of going through a prior authorization, and I was just thinking, why am I the one having to actually go out and go back to my old provider and reach for all of this information? All of this information is really should be more seamlessly exchanged across healthcare providers, across health plans. And that's really the intent around the interoperability final rule. It's intended to be a foundation to really help accelerate and push the industry towards more common data sharing practices across the entire healthcare ecosystem.
So I can definitely see the benefit for members like you and I and millions of others. Within the P2P mandate, what are the benefits for payers? Like, why would this be a good thing for payers as business organizations?
That's a great question. And so we've had the fortunate opportunity, and I know we'll dive into this topic in more detail over the course of this podcast, building out a peer-to-peer connectivity hub solution at Availity. And we did so in collaboration with a number of our health plan customers to really help support them in meeting the peer-to-peer mandate and making it more easy to facilitate the exchange of that member information across health plans. And so through that collaboration, I've been asking these very same questions. And I think that, a few of the value propositions that health plans are thinking about is the way things work today. A member enrolls in a health plan, they get an ID card in the mail, and they schedule their first appointment with their doctor at some course over the year. And ultimately, that health plan will get a claim from that appointment. And that is the very first and only piece of information they have that communicates anything about the health of their new patient, their member. So now that appointment could happen 2 weeks after open enrollment, or it could happen 6 months after open enrollment. So when you think from a health plan perspective, and as you think about health plan operations, and the large programs that they help to support to really ensure that they're delivering the best possible care to their members, whether that be care management programs, disease management programs, measuring for quality and HEDIS reporting or risk adjustment. All of these operations require clinical data. They might require historical claims information or historical authorization information. And with the peer-to-peer rule now, on day one of that individual becoming a new member to the health plan, that health plan can request all of that historical, clinical, and claims and authorization data on that member. So they will know who their providers are. They will know what clinical conditions they have. They will know which potential disease management programs that they can enroll in on day one. And that, not only leads to a more efficient and effective care for their members, but also a better experience for the members and the providers who also serve them.
So I do want to talk to you about the fire standards that are in the final rule as well as the APIs. But first, I wanted to ask you a little bit about some of the challenges of coming into compliance with this rule. So on the surface, the way you've kind of explained it seems like such common sense for a member's data to follow them as they move to different health plans. It makes perfect sense, but of course, the devil is in the details. So could you talk a little bit about the challenges health plans face with exchanging member data, particularly in terms of like the technical complexity, the costs, and of course, as always, resources?
Absolutely. There are so many challenges. I think that the biggest challenge that health plans are facing is that they have numerous interoperability mandates that are coming due, and each mandate is going to require time and resources to implement their respective APIs. And I'll be very blunt. If any health plans are listening to our podcast today, you are underestimating the time and effort and cost it will take to stand up these APIs and enable the workflows that they support. So you need to be thinking about solutioning for them. Certainly today, if not having already been thinking about this. And while there are implementation guides to help guide efforts, so there's the PDEX, for example, for payer to payer. There's standards bodies out there who are trying to put forward a standard way for implementation. We are finding that especially working with a few of our health plan customers on payer connectivity, that everyone's underestimating the work and level of effort and complexity involved, and that the guides are only going to get you so far because there are in fact gaps in them. And in addition to that, I do think too, specifically around payer to payer, one of the other challenges that many health plans are underestimating is this idea of managing dynamic payer catalogs and health plan authentication. So if you think about payer to payer and the idea of exchanging information between health plans, you are going to need to manage all of the different payer endpoints in a directory. And that is going to play a critical role in maintaining the accuracy and timelines of health information exchange across different healthcare entities. And these directories, I think there's tremendous value in acting as a comprehensive database that catalogs these various endpoints, each representing a different payer or health plan within a centralized network. But there are challenges when it comes to managing these endpoints, especially for large health plan systems that oversee multiple state branded plans. We were engaging in our first cohort with a number of these larger health plans. And oftentimes, the health plan name familiar to members differs from the parent company. And this discrepancy can make it really difficult to keep systems up to date and could complicate the process for members trying to find their previous health plan from, drop-down lists that displays names of parent companies. And that's something that we actively, discussed and talked through and worked with during our first cohort of health plans within our peer-to-peer connectivity hub.
So I'm very excited to kind of dig into that cohort work that Availity has done with those 3 health plans. But first, I wanted to kind of walk through the rest of this explainer about the mandate to really kind of talk about FHIR standards, the role of APIs. So obviously the CMS final rule does emphasize FHIR standards. So my question to you is like, how does the peer-to-peer API adhere to these standards, and what role does the DaVinci PDX implementation guide play in that process?
So it might be helpful to also take a quick step back and just level set on FHIR in general, because it is such a common foundation to the interoperability mandate and these APIs. So FHIR stands for Fast Healthcare Interoperability Resources, and it's a standard for exchanging health information electronically. It was developed by HL7, a leading standards development organization for medical data in the US and internationally. And FHIR, what it essentially is a language for health data that allows information to be exchanged and understood across organizations and applications using an API, that application programming interface. And there are 4 things that are unique and make FHIR quite special as a data standard. There are other standards out there. There's, EDI standards. There's the CCDA standard. There's HL7v2 standard. But FHIR has 4 unique things about it. First, FHIR is a standard for both data transport, specifying how healthcare data is transferred from point A to point B. But it's also a content standard, specifying how data can be transferred. So that combination of saying both how data should be transferred and how that information should be structured is very unique. Also, FHIR uses more modern technology, so it supports 4 different interoperability paradigms. It supports REST, JSON, XML, and RDF, and it's also open source, so it's free. And then finally, FHIR is broken down into more granular response or resources, which make it a much faster and more nimble and easier way to exchange data that provides a lot more efficiency and agility. So all 4 of the APIs that we've been discussing in that interop rule specify FHIR as a chosen standard of data exchange, and CMS in general is making a big push toward FHIR being the future standard of data interoperability. And the peer-to-payer rule requires the use of FHIR and strongly recommends the Payer Data Exchange or PDEX implementation guide. This is what I was referencing earlier in our conversation. And that PDEX implementation guide, it's designed for payers and health plans to help them create a member's health history using clinical resources based on the FHIR R4 standard. And this information can be understood by providers and, if they choose, also integrated into their EMR systems. So the DaVinci PDEX implementation guide, it serves as this use case implementation roadmap for health plans to really navigate the process of payer data exchange. However, health plans who have attempted to establish connections in the real world, and as we encountered working with our health plans in our first cohort of peer-to-peer connectivity, we found that there were some hidden challenges that the implementation guides did not capture. And that's why we established this cohort program with 3 national health plans. Availity officially initiated its first cohort back in August in 2023. And, we met consistently with different participants and really collaboratively were able to address 2 fundamental questions. First, how do we uncover any hidden challenges or pitfalls associated with the payer-to-payer connections? And secondly, how do we determine the most effective and repeatable process for establishing connections with other payers, particularly around these gray areas of the implementation guide? How can we design a multi-payer approach and a standard approach to really drive and scale connectivity?
So one last question before we get into the actual cohort framework. So The API retrieves various types of data, including clinical claims and prior authorization. So, can you walk me through how this data retrieval process and the Availity P2P connectivity hub work? And maybe talk a little bit about what the P2P connectivity hub is.
Absolutely. So, in its simplest form, what our peer-to-peer connectivity hub really is, it's a means of driving economies of scale of establishing one-to-many connections across our health plan customers. So, without the peer-to-peer connectivity hub, a health plan will need to establish point-to-point connections with health plans. And if you think about the, hundreds of health plans across the country, there's really no economies of scale. Like you think about that, you connect into one health plan, you really only connect into one health plan because every health plan is implementing their peer-to-peer API in slightly different ways. So Availity is really trying to leverage the fortunate position we have in the market today, sitting across a broad network of both health plans as well as providers of really being that connective tissue of being able to facilitate connectivity more seamlessly and easily for our health plan customers. In our peer-to-peer connectivity hub, it has three primary steps. The first one is that the member opts in for their new health plan to request their data from their previous plan. And so three scenarios can unfold when they do that. The member can provide their former member ID number and the name of their previous insurance carrier to their new health plan. Or the member doesn't know their former member ID number, but they do know the name of their health plan and their prior insurance carrier, and they can provide that to the new plan. And in that situation, the new plan then can facilitate that PDEX member match operation with Availity. And then the third option is the new member doesn't know their former member ID number or the name of their previous insurance carrier. And the new health plan can facilitate a member match across payers to try and locate that available data. So that's the first step in our peer-to-peer connectivity hub. Once member matching has been completed, a peer-to-peer API call is made to the connectivity hub, and we facilitate and enable confirmation of the member's information with the old plan. So we play the important role of one, ensuring that the requester of information is a valid plan and that they have member information that matches. So we provide security clearance and obtain that through a token request, ensuring that authorization access is provided to the member's data. And then the third step is the new plan requests and receives the member's information from the old plan, with all that data seamlessly being managed through the connectivity hub. And everything that I just laid out there, it may sound simple, but without that proper framework for facilitating the exchange of data, payers might struggle to respond to information requests or process that data from other payers. And, that can introduce privacy concerns and risks. And certainly lead to delays in treatment reviews, approvals, or other critical decisions relying on this data.
So I wanted to kind of get into the actual peer-to-peer data exchange cohort program that Availity launched last year. So can you tell me a little bit about that initiative, its structure, and what its ultimate goals were?
Absolutely. I'd love to talk about our cohort. And, I love to talk about this particular topic because as a product leader, it's so important to me to have customers at the table with you when you're building new solutions. And we've had such a collaborative group of health plan partners. They've been absolutely fantastic innovators with us. And this idea was really born not too long after the proposed payer-to-payer mandate was released. And at Availity, I joined Availity a little over 2 years ago, and it's been such a joy being a part of Availity because I think in no other organization across the healthcare ecosystem really understands the complexity of trying to facilitate data exchange across multiple different data standards, types, and organizations. And in addition to that, we have such an extensive network of payer customers and are already facilitating billions of transactions across health plans today. And so, at the time of the proposed ruling that came out, one of our customers came to us and asked whether, given our large payer customer base, were we thinking about, being able to help facilitate a more centralized hub, a one-to-many connection point designed to support health plans exchange data. And we thought that idea made complete sense given, Availity's broad health plan customer base, as well as just our own involvement within exchanging information between healthcare stakeholders. And so Availity, we officially initiated our payer-to-payer cohort in August of 2023, so a little over a year ago, and we embarked on this really dynamic partnership with a select cohort of payers to really pioneer and establish, what we think of as the inaugural set of payer connections within our connectivity hub. So over the course of 8 months, we met weekly, and we orchestrated recurring workshops uniting technical teams from each health plan. And these gatherings were really dedicated to exploring strategies and different ways to consider executing the payer-to-payer data exchange. And so we had participants engage in discussions covering, their organization's overarching interoperability strategy, resources involved for implementation and testing, sharing valuable lessons learned to foster adoption and promote success. And the goal of the cohort was really to address two fundamental questions. First, uncover any hidden challenges or pitfalls associated with payer-to-payer connections. And second, determine the most effective and repeatable process for establishing connections with other health plans.
So I imagine as you made your way through this process, there were challenges and opportunities that you had anticipated. But I wanted to ask, what challenges kind of came out of left field? Was
Mhm.
anything that happened that you were just not expecting initially?
We definitely encountered challenges, and that was a great part about the cohort too. Is we had multiple health plans at the table with us, solutioning and working through those challenges. And I alluded earlier in our conversation that while there are implementation guides to help guide pair-to-pair connectivity efforts, the guides only get you so far because there are gaps in them. And so just to name a few of the challenges we encountered, specifically for pair-to-pair, the Da Vinci PDEX implementation guide, it essentially serves as a use case implementation roadmap for health plans who are looking to navigate that process of facilitating pair-to-pair data exchange. But in our experience working with these guides and working with our health plan customers who have attempted to establish real-world connections, we encountered hidden, unanticipated challenges that the guides did not address. So for example, there were dead links. So several references within the guides led to non-existent pages, and that caused navigational issues and in general made more of a comprehensive understanding of implementation challenging. But there also were discrepancies between the PDEX implementation guide and the actual mandate, and this is kind of known in the industry. But for example, version 1 of the guide mandated that members possess credentials with both their new and old payers, but the CMS mandate dictated that members only need credentials with their new payer, which then communicates directly with the old payer. So what do you do in these situations? And again, that was the real value. Our mission at Availity, I think, is really driving multi-payer solutions, and a real value add of our pair-to-pair cohort was again that we could take these ambiguities and really drive consensus and alignment across our health plan customers to clarify those ambiguities. Thinking of another unforeseen challenge, we found that also proved helpful to really talk clear with our cohort of payers was the challenge around health plan authentication. So in building out our pair-to-pair connectivity solution with the set of health plan customers, questions emerged from our health plans of, how do you vet that requests coming into them are from legitimate sources or good actors? There's a lot of bad actors out there. There's a lot in light of, recent security breaches. There's a lot of concern around making sure that, what we are doing is we're doing in a very safe way when we're looking to exchange information, especially when it is, it is personal health information. And that's something we decided to take on as a part of our pair-to-pair connectivity hub value is that Availity will validate payers so that any customer of ours can trust that requests coming in through our network are valid and legitimate. And so for payers not leveraging our solution, thinking through how do you authenticate and validate requesters to ensure who they are is actually who they are is really, really important.
So I wanted to ask you a little bit about the cohort's approach to testing and validating the P2P solution, and then really what lessons you kind of drew from or best practices from planning for infrastructure and testing for a solution like this.
Absolutely, yes. Establishing seamless connectivity between payers, it demands adherence to specific infrastructure requirements and the implementation of standardized processes. It was something we certainly had top of mind throughout this whole process. So to ensure those smooth operations and effective data exchange testing, we required cohort members to meet a few prerequisites. So first was having a QI environment. So payers and other participating entities had to possess the necessary capabilities within their own quality assurance environments, that allowed testing grounds, so to speak. And so these environments needed to include the implementation of the PDEX, the 2.0 version of peer-to-peer API. We required that there be configuration of the peer-to-peer API to respond with test data in the FHIR format. We required ability to send a request for a patient data to the Connectivity Hub's API server. And then we also required the ability to respond to a request from the Connectivity Hub. And really what this enabled too was a common foundational starting point for all of our health plans to engage with our peer-to-peer hub. Second was a production environment. So, you have to get the QA environment to do all of the testing. And then, once you get through all of that testing, a live production environment. And so prior to executing an agreement with our participating payers, they were required to make their peer-to-peer APIs available in production environments to Availity. So these requirements ensure that the infrastructure is ready and that there are standardized processes for successful connectivity and data exchange within the cohort. And then the last piece was ensuring the reliability and interoperability and security of our connectivity solution. That is paramount to us. And so that's why we actually developed a mock payer service that provides a simulated environment for cohort members to test and verify their system's capabilities to send and receive simulated data end to end. So this service is designed to mimic the behavior of a real health plan. It allows users to conduct thorough testing of their systems under controlled conditions, and is a great way too before a payer starts engaging with another payer with real data that they have the opportunity to engage with that mock service.
So, Ashley, obviously the cohort health plans and their peer organizations are going to be on the hook for coming into compliance with this final rule. So I wanted to ask what what lessons you drew from the initial implementation, and how that kind of informs your strategies or recommended best practices for other payers who are looking to implement a solution like this.
Yes, I I would say three specific lessons to me come to mind. So first is just the importance of preparation for that 2027 enforcement deadline. I said it earlier when we began, and I'll say it again to you, our listeners. Um, Even if you think you might have a handle on the amount of work it will take to comply with these mandates, please be understanding that you are likely underestimating the amount of work. So you really must begin to start working on this now. You have to begin thinking about this now. Transferring member data to a health plan, after a patient provides consent for their new plan to obtain those records from a prior plan, it involves a complex technical sequence comprising three critical steps, authentication, member matching, and data retrieval. And in the absence of a robust data exchange system, payers might face challenges in responding to information requests or managing data from other payers, and that could lead to privacy issues and delays in critical decision making. So it's really important to really think through preparation. And I learned in the first few months of convening with the cohort work group, we did encounter numerous decisions that were not explicitly addressed in the mandate. So we had to navigate through these intricate details. We had to navigate through some grayness and some uncertainty, which were not necessarily outlined in the implementation guide, but did require resolution nonetheless. Another example, I provided a few, but another example that comes to mind was determining whether to support mutual authentication for automated endpoint discovery or opting for an alternative solution was among the deliberations. And so while some of these details were implied or suspected in the implementation guide, we did have to collectively make these decisions as a group. Second would be to test early and plan for time to iterate based on testing, because I think we all of us in product and development, we want to build something to be perfect, but you can't foresee every circumstance. So as we gathered with this cohort and initiated our preliminary discussions, the primary focus really shifted towards realizing our conceptual solution into a tangible reality. And so, we initially brainstormed and explored various features and capabilities that we thought would be suitable for our inaugural cohort. And while these discussions and interpretations were tremendously valuable, the critical question remained of how can we practically test and integrate our solutions? That was the end goal at the end of the day. And so hosting live testing workshops that resembled mini connectathons with our health plans was proven to be highly effective. And during our testing workshop, we made significant progress in validating that our service is functioning as expected. But even amidst our efforts to conduct tests, we did encounter challenges that we needed to work through together that underscored the complexity, again, that every payer is going to be facing should they be doing this on our own. And then I would say, building on this, that the third, lesson learned and kind of best practice that I would offer up is that that end-to-end testing really is crucial. So, during the May 2024 Connectathon, we observed that some vendors are still grappling with the basics, with authentication steps between their servers. And these observations, they highlight the pivotal need for payers to address these challenges. And through proactive engagement and issue resolution, supported through testing, health plans can really ensure they meet compliance standards effectively and maintain the smooth operations as deadlines do approach.
So if health plans are able to successfully come into compliance with this mandate, I imagine the very next question they're going to ask is what's next? How does this capability evolve? How does it lay the groundwork for future interoperability initiatives and data sharing opportunities? So that would be my question to you is like, what's P2P 2.0 look like after the
Mhm.
compliance date passes?
It's a great question, Matt. If only I had a crystal ball. But I do think, again, taking a big step back. At the end of the day, what the interoperability rule is really intending to advance and push forward is more seamless data exchange, and different APIs are sort of tackling different stakeholders and different use cases. But with payer to payer in particular, I think again it is this idea of how can we help ensure more holistically seamless data exchange is being transmitted really on behalf of the member, so that you said it yourself in terms of seeing the value in pair to pair, that all of your health information stays with you regardless of what health plan you're at. I do think, though, that and we saw this a little bit with the patient access API. So this came out first. It came out back in, I want to say it was, I think, 2020. And to be honest, I think it was a soft mandate in the sense that, it was a mandate, but there weren't strong penalties if you really didn't implement it. And, we even saw this too with a proposed pair-to-pair mandate that the government kind of delayed the eventual final rule to be 2027 to allow health plans more times to comply, because this is a lot of work. It is going to take a lot, and the biggest piece that I see in general is again, it's just kind of a crawl, walk, run approach of data interoperability and data exchange, where I think pair to pair as a mandate is tremendously valuable, but I do think there's my hope for the industry is that they're not that we're not going to be using these mandates to merely check the box, but actually think about how do you activate these mandates for use at scale, and how can we think about the value and opportunity of taking in historical information and being able to act upon that, to what our cohort members are really striving to do around, on day one of a member becoming a new member for your health plan. How do you get them, enrolled in the right care management programs so that, you can give them the best care possible, as soon as they become one of your members. But that's going to take more work than merely, checking the pair-to-pair box. That's going to take the work of being able to stand up the API, of being able to actually use it at scale across, all different health plans, and being able to consume other health plans' FHIR data, which, is a whole other hurdle in and of itself to overcome. So I think that there's still more work ahead for us as an industry to really drive the actionability of information as it's more seamlessly exchanged. But I think too that affords us so much potential.
So I think you've been really forthcoming in terms of the complexities of making this happen and making this a reality, and that this journey for pair-to-pair data exchange does have a lot of variables to consider, that there's a lot of nuance and challenges to ahead of you. But I wanted to kind of close this conversation by giving you an opportunity to offer some advice to the health plans that are listening in. How do they lay the cornerstone for this journey? What are the proper first steps to make sure they get off on the right foot as they move along toward compliance?
I think, well, first and foremost, I hope those who are listening would be interested in joining our network of health plans that we can really help accelerate, their own connectivity across the industry, but recognize too that, that everyone is going to be taking on this journey in different ways. I would say three best practices to offer up, is really thinking about first, unlocking the efficiency and flexibility around endpoint directories. So, to be successful here, you know, you are going to need to be managing if you're not leveraging a connectivity hub like Availity or solution like Availity, all of the different health plan endpoints. And, our response to the complexities of individual health plans managing their own payer catalogs was to create a centralized directory of networked payers. So I would be thinking about how can you kind of manage, the various different health plans that you will be connecting to. I also think it's important to strike the balance between agility and standards. So, within our pair-to-pair data exchange cohort, we did embark on this journey that really illuminated the importance of striking a balance between readiness, agility, and community collaboration. So, in our journey with the initial cohort of pairs, we discovered what was required and recommended standards that were not inherently sufficient. So, at the outset, that PDEX standard had published a version 1 specification, which was only available and standard for use. There were ongoing efforts to build up a version 2, but we couldn't wait necessarily for that version 2. So we made the collective decision early on to let's adopt that, and let's make sure as we're building with the ability to be agile and modify and adjust as we're proceeding with the build of our solution. And then the third thing is I think ensuring transparency. So when health plans start to exchange data with each other, shortcomings may emerge due to differences between systems and data quality issues or integration challenges. So we try to provide comprehensive reports that detail information like network size and transaction volumes and validation issue trends. That in the absence of that too, I do think building such capabilities within a health plan itself, just to ensure that there's transparency in the information that's flowing into your system, the information that's flowing out of your system, can lead to more efficient and secure data exchange.
That sounds all fantastic. Ashley, thank you so much for taking the time to explain the mandate and the cohort and the potential for health plans to really change the game when it comes to data exchange. I appreciate your time.
Thank you so much, Matt. I really enjoyed our time together.
Thank you for joining us on this episode of Availity on Air. Special thank you to Ashley Basile for sharing her expertise and providing a deep dive into the complexities and opportunities of payer-to-payer data exchange. If you'd like to learn more about this topic, be sure to check out the show notes for additional resources and links. And don't forget, if you have an idea for an episode or would like to be a guest, feel free to reach out to us. Availity on Air is produced by Availity LLC, with editing, music, and graphics by Kevin McDonald and research by SVM PR. As always, thank you for tuning in, and we'll see you next time on Availity on Air, where we will explore the power of innovation and healthcare technology. Okay, that's it.